and HBO, what we know and what we don't know. I'm going to plug in for American College right now. And if you're not a member, please become a member of American College of Hyperbaric Medicine by going on that website, achm.org. ACHM is the professional society dedicated to appropriate utilization, standard of care, education, training, certification, and recognition of hyperbaric oxygen therapy as a distinct medical specialty. The American College of Hyperbaric Medicine was founded in 1983 in support of clinicians practicing hyperbaric medicine who recognize the importance of therapeutic oxygen in clinical application, especially wound management. It was one of the first. The college was the first one to get a CAQH for hyperbaric medicine subspecialty. Just want you to remember that you can, the Zoom conference that you are having today, if you like it, we're going to do this every monthly, become a member, and then we are having an annual meeting with 12 hours of CME and CHT hours on October 24, 25. So please go ahead and go on achm.org. This is going to be the first digital advanced wound care and hyperbaric conference. You're going to love it. We have a great panel and we'd like you to be there. So today, I just wanted to, I want to invite you to this webinar and understand that we all are here because we all are experiencing the worst pandemic in 100 years that has rapidly transformed the lives across the globe. Social distancing, mask for all, and hand washing has become kind of a norm and has become an extremely important to prevent spread of disease. Hyperbaric centers all over the world are wondering what are the best practices regarding chamber cleansing, social distancing, masking in monoplace and multiplace chambers. We have some speakers who have treated COVID-19 patients firsthand, and they're going to share their experience today. This webinar really seeks to separate fact from fiction based on the best available science and explain what we know on what we don't know about COVID-19 and HBO. So again, we're going to talk about science. We're going to talk about the Chinese experience. We're going to talk about the US personal experience from two centers. We're going to talk about cleansing and guidelines for both monoplace and multiplace chambers. We're going to talk about the oxygen delivery by hood. We're going to talk about international and national guidelines for treating COVID-19 patients. If you are going to get a CME certificate, if you're a physician, then we would like you to, if you're going to claim a CME credit, a TMA online evaluation tool will be available within 7 business days after this course is done. Each attendee will receive a separate email from the TMA CME team, which will include a link to the short course evaluation, which will need to be completed before being able to claim credit. A certificate will automatically be generated and sent to the email address the attendees enter after. This activity has been planned and implemented in accordance with the accreditation requirement and the policies of Accreditation Council of Continuing Medical Education through the joint providership of Texas Medical Association and the American College of Hyperbaric Medicine. This activity is a live educational activity and the maximum of 1 AMA PRA Category 1 credit can be obtained, and physicians should only claim credit that commensurate with the extent of their participation in the activity. The activity has also been approved by the National Board of Diving and Hyperbaric Technology for 1 contact hours. At this point, I will give you disclosures. None of our speakers have nothing to disclose, and I as a planner has nothing to disclose. We want to thank our generous supporter for this webinar, Secret Industries. Thank you for supporting this webinar. This educational activity will be a great platform for a lot to learn about hyperbarics and COVID-19. I'd like to let you know, give you a disclaimer at this point. The views expressed during today's webinar are the personal views of individual presenters and not necessarily of the ACHM. The personal experience shared by Dr. Denham and Dr. Thibodeaux with COVID-19 and HBO therapy was used as a part of compassionate care and off-label use. Both doctors have extensive experience in hyperbaric medicine, and their teams are trained in critical care management. Both doctors treated these patients with hyperbaric chambers and not portable chambers. Beware of freestanding chambers advertising COVID-19 treatment with HBO without qualified healthcare professional trained experience and equipment to practice with a strict infection control. I want you to just make sure that ACHM has endorsed the position statement that was given by UHMS on COVID-19 and HBO, which is on our website. And if you end up treating any patient with COVID-19, the ethical guidelines will remain the same as it is for an off-label use, which is also on the website on ACHM. ACHM also published a recent white paper on office-based hyperbaric oxygen therapy. I will let you review that after going on that website. So now I will introduce our first speaker. I will get Dr. Paul Hodge to share his screen. He's an emergency medicine and hyperbaric medicine clinician who is a clinical professor of medicine section of emergency medicine at LSU School of Medicine, New Orleans, and former director of University Medical Center Hyperbaric Medicine Department and LSU Hyperbaric Medicine Fellowship. Dr. Hodge.
Thank you very much for the invitation, and this should advance. We practice this. There we go. I'm going to talk about the science of COVID-19 infection and the application of hyperbaric oxygen. Basically, coronavirus is an RNA virus. Primarily infects humans. It's similar to SARS and MERS. And clinically, though, it's very similar to Spanish flu. And that's what I want to draw a correlation to here today. It's highly infectious. Comorbidities are important, especially in the elderly. Obesity seems to be a big risk factor. Natural history of the infection is incubation for about 5 to 6 days, and then a period of infection of about 48 hours. Symptoms are fever to cough, malaise, and shortness of breath. About 40% have mild disease, 40% moderate, and then the rest have severe disease with 3 to 5% developing acute respiratory distress syndrome. Clinical deterioration usually occurs on or about day 7 of infection. Our experience has been once they hit the ER and get admitted, they've got about 48 hours to stabilize or deteriorate. Once they deteriorate to a non-rebreather mask, it's generally been about 12 hours before they're intubated. In one Chinese study, the average time from ICU admit to death was 7 days. Lab findings: decreased lymphocytes and percent of lymphocytes, decreased liver function, increased D-dimer and LDH. Inflammation is dominant, mostly in the lungs, but also systemically. And the findings in the severely ill are on chest X-ray and CT, ground glass opacities. Pathology from multiple autopsy studies on small numbers of patients show that inflammation is the dominant pathology, mostly in the lungs, but also systemically. So essentially, we have a primary clinical problem in COVID-19 of a pneumonitis, and the itis is key because it's an inflammatory problem in the lung that develops progressive hypoxemia and a cumulative oxygen debt that has to be accounted for. This is essentially a wound condition of the lung. So if you look at the top here, our normal lung tissue, fine, delicate, kind of honeycomb structure, and a COVID lung on the right-hand side. And the main finding here is the barrier to diffusion of oxygen, where the alveoli fill up, the interstitium becomes edematous on the bottom. There's a Chinese patient over a 4-day period of time showing the progressive lung involvement in ARDS. This is just a quick slide from the latest WHO report 2 days ago showing that worldwide this infection is not decreasing. Okay, hyperbaric oxygen, what are we doing? Well, we know it's a combination product of hyperoxia and hydrostatic pressure. In the US, we primarily treat wounds, much larger list internationally, but it's a treatment for disease pathophysiology. It is the ultimate treatment for hypoxia with powerful effects on inflammation, which is primarily, I believe, the effect here in COVID-19 patients. The best example is all of the data on reperfusion injury, but also there are widespread gene expression effects. And amongst the largest clusters of genes that are turned on are the anti-inflammatory genes, and amongst the largest clusters that are suppressed are the pro-inflammatory genes. So here's our list of typically reimbursed indications in the United States, and I've grouped them. You can see they're all wound indications. I reordered them, though, to put all of the infectious ones at the end and make the argument that they are also wound indications, very similar to the wounding that we have in the lungs. So what is hyperbaric oxygen doing, and how do our lungs oxygenate? Our lungs oxygenate by Henry's law. So if we look at the alveolus here with all of the gas in it, oxygen in red, it has to be dissolved in the liquid portion of the alveolar membrane, the interstitial fluid in white, finally the capillary cell wall, the plasma of the capillary, finally the cytoplasm of the red blood cell, and then bind to hemoglobin. And progressively, as the blood passes over the alveolus, it is oxygenated. So Henry's law, as we know, if the lungs were breathing room air, 21% O2, we have enough in our blood to satisfy our metabolic requirements. You put on 100% oxygen, you have a whole lot more than we need. But what's the problem in coronavirus infection? In the lungs is the barrier to diffusion caused by the intense inflammation in the interstitium and the alveoli. Well, what do? How do we get by that? We just take Henry's law to the next level and we increase the pressure above atmospheric pressure. So if on the left-hand side, this is our COVID lung on 100% non-rebreather mask with barely enough oxygenation or not enough, at 1.6 atmospheres, for example, we have a lot more in the lungs, it gets into the blood, and we're able to sustain life. So in summary, what we're doing with hyperbaric oxygen, we are treating oxygen debt. This has been well shown in animal experiments with resuscitation. It has anti-inflammatory effects, multiple experiments done on this. The references there on this slide and the previous ones, especially gene expression effects. And then we have daily permanent effects, as the Chinese data will show. What we don't have are antiviral effects. There's no evidence yet for that. The net effect is we are tiding patients over the critical part of the illness until host defenses catch up and the virus burns itself out like all viruses do, or in the lesser ill patients, we're preventing deterioration and hopefully intubation. Okay, I'm going to just morph into the second talk since these are back to back. And this one is on the Chinese experience. And I want to start out by discussing January and February. My staff and I had extensive discussions on how we might be able to apply hyperbaric oxygen to COVID-19 patients. So what I reminded everybody was we forgot 102 years ago, the initial application of hyperbaric oxygen in the United States, the very first patient were dying Spanish flu patients, almost identical to the COVID-19. Cunningham only had compressed air though, and he took them to 10 PSI initially, 1.6 ATA. If he went up as high as what they did in the late 1800s to 4 ATA of air, the most oxygen he got was 0.84. What he did though was salvage patient after patient, and that introduced hyperbaric medicine into the United States. So there's an effect of pressure here, hydrostatic pressure, in addition to oxygen that seems to be affected. So I finally put an internet post about this on March 10th, just essentially calling everybody to start trying this in the absence of any effective therapy, to begin studies, et cetera. Within 24 hours, we found the kind of pre-release Chinese article on the 5-case series that had been translated in English by a doctor in, I believe it was Iran. I then had an hour-long interview with the treating doctors in China and extensive communications over the last 2 months, getting information from them. Essentially, they had the identical experience to Cunningham. And they noted this even when the mask fell off in the chamber. They maintained oxygenation, or when they compressed them on air. I put this information in front of Governor Cuomo and Edwards of Louisiana. They demanded published information. We tried to get this published in an English language journal. It resulted in a commentary in Medical Gas Research. And then just last week, the Chinese doctors were able to get it published in China. So this is now the Wuhan experience of Dr. Zhong, Chen, and their colleagues. And the first case was a case report on a ventilator-dependent patient. They only did 4 hyperbaric treatments at 1.6 ATA for 100 minutes. But if you look over here on the right in their flow chart, in addition to the description at 1.6, they have 1.8 in there. So maybe they gave a couple different doses. Here is the graph of the arterial blood gas data. And you can see at the initiation of hyperbaric oxygen, this really isn't an impressive improvement, but nevertheless, they were able to get the patient off the ventilator, salvage him, and discharge him from the hospital. The second report was the case report of the most severe one from the 5-case series. And they treated this guy at 2 atmospheres for 90 minutes at depth, first treatment, multiplace chamber by bibs. Second one through the 8th treatment, 2 atmospheres for 60 minutes at depth, also by bibs. And here is the pulse ox data on a daily basis. The morning values in pink on the bottom, the purple is by 4 p.m. And the first hyperbaric treatment was here on February 12th. So you can see the patients seemed like they may have been starting to improve. Dr. Chen said he really wasn't, but the point is, got better, they had a successful outcome and salvaged the patient. The third one is the 5-case series. And these were all people who were failing mask therapy, and they don't use a non-rebreather. They use a venti mask where they estimate FiO2 is about 50%. They delivered an average of about 4.6 hyperbaric treatments once daily in their multiplace chamber. First treatment for all of them except that first one was 1.6 atmospheres for 90 minutes. The second to the 5th treatment was 1.6 for 60 minutes at depth, all by non-rebreather mask. They estimate 95% PO2. And the net result was increase in pulse ox, arterial oxygen, lymphocyte number in percent, decrease in fibrinogen and CRP, the inflammatory markers they used, and an improvement in CT of the lungs. The conclusion was an improvement in hypoxia, oxygen debt, microcirculation, and immune function, and a salvage of the patients. This is the demographic chart that I made with them. And I abbreviate it, but I just wanted to show the pulse ox and arterial O2 of these 5 patients before they started hyperbaric oxygen. And these are values while they're on oxygen, I believe. We had some discussion about that. This shows that all 5 patients, on average, were on mask oxygen for about 12 days before they got in the chamber. Afterwards, a short period of time on mask oxygen, then nasal cannula, and finally discharge. Here's the daily pulse ox graph. On the right-hand side are all the colors for the individual patients. You can see the rapid day-to-day improvement and intraday improvement with each hyperbaric treatment, except for that most severe patient they treated at 2 atmospheres, had the least daily change. I don't know if that's a dose effect or whether it was just because of the severity. This is kind of the money graph, though, showing the transient and permanent effects of hyperbaric. So these are the composite 5 patients. Blue line is before hyperbaric treatment each morning. The pink line is right after they came out of the chamber, and you could see the marked improvement. They drifted down, but by the next morning, there was a progressive, durable improvement, and the patients were successfully treated. Here are the CT scans of the lungs, top row, before, after, on the bottom, all showing improvement. So the cumulative experience, as it turns out, after they treated these 6 very ill ones, 29 patients demanded from the hospital administration that they be treated because they saw how quickly the more severely ill ones had improved. And the hyperbaric doctors were pressured, if you will, by the hospital administration, and he treated all of them. There was no cross-infection to any of the hyperbaric staff. All 35 discharged from the hospital well, and no complications. I was very concerned about cross-contamination because of some announcements on the internet after we made this post about people offering immune booster treatments in freestanding facilities. This was all done with strict infection control. These actually are the staff on the outside of the chamber. They had organized the whole department with pathways, especially for the patients, etc. The inside attendants were in a separate lock and never entered the chamber, but also well protected. So no transfer of infection. Lastly, what I want to point out is this is not new. HBOT has been used for ARDS, and it was done in Russia in 2003 with 45 blunt chest trauma patients, all of whom developed ARDS within 48 to 72 hours of the blunt trauma. They had 2 groups, one that got no hyperbaric treatment, 18 patients. The other group got hyperbaric treatment, 8 patients, and 1.6 to 2 atmospheres. And look at this short amount of time that they spend in the chamber once a day for 4 to 15 hyperbaric treatments. Outcome, 77% mortality in the non-hyperbaric group, 0% in the hyperbaric group. This is essentially what we're treating in COVID pneumonia. This is a compilation of all of the trials that are now listed on clinicaltrials.gov as of this morning. And you can see the varying doses that are used: 1.6 ATA for 60, 2 atmospheres for 90, 1.6 to 2.4 for 30 to 60 minutes. This is close to the Rogotsky ARDS dose, 1 to 7 treatments. Some of these are not recruiting yet. In Israel, 2.2 for 60, 8 treatments in 4 days. The others didn't mention and are keeping private their dosing. Lastly, I want to congratulate everybody, everyone who's been able to do this. This is really a daunting task. It's critical care. Our IRB has approved our study and our hospital's blocking it, so we're still stuck waiting to start our study. But again, congratulations to everybody who's been able to get this done, and thank you.
Thank you, Dr. Hodge. That was an excellent presentation. Now we're going to hear from the real heroes, the brave fighters who have been fighting and helping our COVID-19 patients. The next 2 doctors have treated these patients themselves. So I'm going to ask Dr. Helen Galley to share her screen because she's going to represent Dr. Daphne Denham. She's a general surgery specialist practicing wound care and concussion treatment with hyperbaric oxygen therapy in clinics in Northbrook, Illinois, and Fargo, North Dakota. Dr. Denham graduated with honors from University of Louisville School of Medicine in 1993. Dr. Denham is treating someone right now with hyperbaric chamber in ICU. She's not able to join us, but she has sent her experience and slides to Dr. Galley. Dr. Galley, will you please share your screen? Dr. Galley?
Yeah, let me unmute. Here we go.
Yes.
All right. Can you see my screen?
Yes, please go ahead.
Okay, great. So I've always wanted to be a general surgeon, so this is my one opportunity to step into that role. Daphne is treating patients currently. Looking at the type of patients that she's treating, this hospital that she's at is near one of the Tyson meat processing plants. So the hospital approached her to treat these patients because they recognized that they would become overwhelmed and this small community hospital would never be able to manage the level of ICU admissions that were projected by their medical director. They're currently using the Mount Sinai Health System treatment guideline intensity scoring, and I've put this up here. So almost all of the patients that Daphne has treated have either had moderate or severe disease by this criteria. Because it's essentially a outpatient hyperbaric unit, they cannot do intubated critical care patients, although they can do some level of supervision or monitoring. So the program was passed through the IRB, started on Monday, April 27th. To date, she has treated 16 patients, of 12 men, 4 women. 13 of those patients, 7 of which met intubation criteria. All of them have been treated, only 3 required intubation. Now, after discussions with Dr. Denham, the 3 that required intubation were in the initial 5 that she saw in consultation. And as Paul mentioned, this is really a work in progress. And you can see from all the different clinical trials, the variety of treatment protocols. Part of it is that we don't know what the best treatment protocol is. So she posted one example, for example, of the good outcome. So she was initially admitted to the floor and then transferred to ICU. She was 69 with diabetes, hypertension, and obesity. She had saturations of 67 to 70%. She ended up getting 10 hyperbaric treatments, was transferred back from the ICU to the floor. And this has been fairly consistent, except for the first bunch where 3 out of the first 5 got intubated, what they are finding is if they treat them a little bit earlier, so the hospitalist intensivist service has to call early so that they can get evaluated, and potentially some patients who are presenting a little later in their clinical course may require twice-a-day treatments in the beginning. So once a day may not be enough if they're presenting later on, as Paul described, that cytokine storm where they start to get worse on day 7. The difference between the time they get admitted to the hospital and when they hit that tipping point may be the marker that we need to use to accelerate treatments. This is a small community hospital and doesn't have an extensive ability to do lab testing. However, CRPs in that particular patient, you can see how even though they peaked, they started to go down pretty rapidly. And I think that there is sufficient evidence that we are really tamping down that cytokine storm, that inflammatory response, and allowing the patients to be able to oxygenate themselves better and their lungs to function better because of decreased edema and obviously increased intermittent oxygenation. So the take-home message is that the protocol is a work in progress. We don't know if we should treat shorter than 90 minutes. Should we treat deeper? Should we treat deeper for shorter periods of time? One of the issues, of course, is the risk for pulmonary oxygen toxicity. What she has done is started proning patients for an hour before treatment because the critical time is the transport. And I think this has been borne out multiple times where patients start to desaturate with the most minimum of physical exertion. So she's also proning them in the chamber to see whether or not that will help. And the other thing that has become obvious is that we have to have maximum ability to do the patients. So the hyperbaric unit cannot be doing walking wounded wound care patients and COVID-19 patients simultaneously from an infection control standpoint. So in this crisis, outpatient services may have to be limited because we potentially have to do them twice a day.
Thank you, Dr. Kelly, for filling in for Dr. Denham, who is saving life right now. And now we're gonna invite Dr. Kerry Thibodeaux. He's a nationally recognized wound care advocate and a board-certified general surgeon, vascular surgeon, and a wound care specialist. Dr. Thibodeaux is a fellow of American College of Surgeons since 1992. Dr. Thibodeaux has been in private practice, specializing in general thoracic, vascular, endoscopic, trauma, and hyperbaric medicine at Opelousas, Lousiana. Dr. Thibodeaux, take it away. Can you share your screen?
Where do you hit? You got it? Okay. We were working on it.
Dr. Thibodeaux, you can start while he's sharing your screen. So
okay, very good. Well, first of all, I'd like to thank Dr. Shaw and the American College of Hyperbaric Medicine for putting on this very important webinar and for allowing us to share our experience with you. On April 13th, we were asked to evaluate 3 COVID-19 patients in the intensive care unit who had deteriorated rapidly over the course of 48 hours and were facing possible intubation. We were able to do a rapid assessment and set up some policies and protocols which would allow us to protect our staff and transport the patients safely and then conduct their hyperbaric treatment. So we'll start with the, so far we've treated 11 COVID-19 patients with hyperbaric therapy for a total of 53 hyperbaric treatments. 5 of those patients have fully recovered and been discharged from the hospital. 4 remain hospitalized, but 3 have been transferred to the COVID floor and are out of the ICU. And 1 patient remains on the vent after refusing further hyperbaric therapy after 2 treatments. We've had 2 deaths. Both patients received 2 hyperbaric treatments. 1 patient expired suddenly on the 3rd ICU day from what appeared to be a massive pulmonary embolism, and the other patient refused further treatment, made herself do not intubate, do not resuscitate, and subsequently expired 2 or 3 days after that. So the first patient was a 47-year-old Black female hospital employee with multiple comorbidities, was in the ICU, had been admitted on the 8th, had deteriorated rapidly, was tachypnic with a rate of 50, was on vapotherm at 100% high flow, D dimers of 21,000, and facing imminent intubation. She was treated 2 atmospheres for 90 minutes, and one of the most amazing things was she became asymptomatic at pressure. Her tachypnea resolved. She reported symptomatic relief of her shortness of breath, and then subsequently fell asleep. And this is something that we've noticed with all of our tachypnic patients. Their tachypnea improves, and they are able to actually get some rest. She subsequently received 5 hyperbaric treatments, and then was rapidly weaned off of supplemental oxygen and discharged to hospital. Her inflammatory mediators fell precipitously following the first few hyperbaric treatments. The second case is a 64-year-old Black female, another hospital employee with multiple comorbidities, again admitted on the 8th, had deteriorated pretty quickly over the course of a few days, tachypnic to a rate of 40, on 100% high flow vapotherm, elevated D dimers and CRP, received hyperbaric therapy 2 atmospheres for 90 minutes, and after 3 hyperbaric treatments, her inflammatory mediators started to fall precipitously. She was weaned off of supplemental oxygen, and once they get below 50% FiO2 and they're without symptoms, in other words, they're not tachypnic, then we hold their treatments. And so she recovered very rapidly after that and was subsequently discharged from the hospital. The third case is a 58-year-old male with diabetes and hypertension, a blood type A. By the way, our sickest patients were all blood type A. I'm not sure the significance of that, but I'm sure that might have something to do with their red blood cells capacity to maintain the ability to oxygenate. Again, admitted on the 10th, deteriorated over the subsequent 48 hours, tachypnic to a rate of 40 on high flow vapotherm, elevated D dimers and CRP. This patient required 11 hyperbaric treatments. He had paroxysmal coughing, which was very difficult for the pulmonologist to actually control. So his improvement was a little slower than the other patients because of these fits of coughing that he had. But I'm happy to report that he's been moved out of the intensive care unit and is being discharged home tomorrow. And again, the same phenomena of rapid decrease in inflammatory markers, such as the D dimers and CRP. Fourth case is a 52-year-old Black female, obesity. I believe this woman was a nursing home employee who contracted COVID-19, was admitted on the 9th, began to require increasing supplemental oxygen and remained tachypnic. This is one of the earliest patients that we were able to treat, which I think was alluded to a little earlier by Dr. Gelly, that if you can catch them earlier, that we might be able to short circuit what happens in terms of the inflammatory process. She required 1 hyperbaric treatment, and by the next morning, she was requiring very minimal supplemental oxygen and was subsequently discharged 2 days after her only hyperbaric treatment. Again, her inflammatory means we measured her D-dimers before and after, and again, a precipitous drop. The fifth case is a 38-year-old female with hypertension, diabetes, obesity, was admitted to the COVID isolation unit after testing positive as an outpatient, presented to the emergency room with increasing shortness of breath, was tachypnic, rate of 40 on 4-liter supplemental oxygen at FiO2 greater than 50%. Her inflammatory markers were not as elevated, but she was very symptomatic even with supplemental oxygen. Underwent 3 hyperbaric treatments at 2 atmospheres and recovered very quickly and was subsequently discharged the day after her 3rd hyperbaric treatment. So we're very encouraged. Our protocol is any patient admitted who deteriorates and has increasing oxygen requirements and remains tachypnic. In spite of that, we're being asked to evaluate them early. We do have 6 chambers. We have a large volume hyperbaric practice, so we're able to treat patients in the morning and reserve the entire unit for the afternoon. The hospital's installed 4 scrubbers, so we are now a negative pressure unit. Our staff gears up completely, housekeeping, cleans the hallway before and after we transport them to the unit, after we bring them back to the ICU. We're in proximity to the ICU, so transporting these patients is relatively straightforward. We have very minimal time where they're not on the high flow supplemental oxygen. So in our experience so far with our 11 patients, we have a 73% response rate, 18% mortality from the 2 deaths, and then 1 patient who was intubated after refusing further therapy who remains in the ICU in critical condition.
Dr. Thibodeaux, this is Julio.
Yes.
There's a question being asked if the patients have fevers while they were being treated.
No. No, all of our patients were afebrile. We also do our pre-dive assessment in the intensive care unit and transfer them to the hyperbaric stretcher and keep them on their supplemental oxygen until the very last minute. We've had some hoods constructed so that we can transport them with high flow oxygen into these hoods, which I think someone will speak to a little bit later. We find that they tolerate the transport back to the ICU with just simple supplemental oxygen. We did manage to do some TCOMs at pressure on some of the patients who were stable enough for us to set that up, and we obtained transcutaneous oxygen measurements of greater than 550 in all of those patients at pressure. So we're convinced that this obviously they're hyperoxygenated. They all have symptomatic relief. They have about 4 to 6 hours before the sicker patients end up with a recurrence of their tachypnea. We have considered possibly doing BID treatments, but so far we've been able to treat them every 24 hours in an afternoon dive slots. But certainly we stand prepared. Any patient that we feel might need a second treatment, since we are on 24-hour call and we do hyperbaric therapy every day in our center, we are equipped and staffed to do them as frequently as we need.
Thank you, Dr. Thibodeaux. Next, I'd like next Marcus Sparrow to share his screen. He's a Chief Operating Officer and partner in the Wound Treatment Center, LLC, at the same hospital like Dr. Thibodeaux. He's a registered nurse and a certified wound specialist, and he firsthand prepared his facility for treating this COVID-19 patient. So we'd like to hear from him about what he did, how did he do the infection control, and what kind of precautions did he do. So let's hear from Dr. Sparrow. Marcus Sparrow. Marcus, can you share your screen?
Thank you, Dr. Shaw. When we first began looking at implementing hyperbaric oxygen on our patients, we worked with the hospital here, Opelousas General Health System. We met with the command center, security department, and environmental services and the plant operations department to see what the best route and what safety precautions would need to protect the patients for the transport from to and from the intensive care unit, and also to protect any staff in the hospital. As we began treating patients, we use our transport gurneys that are used to go into the chambers. Those are what we transport our patients on. The staff, all practices, social distances, everyone's dressed out in full battle gear with all the PPE. We notify security and also environmental services and the intensive care unit which patients we will be transporting for their therapy. Security comes on site, they secure the corridor. There's a couple of elevators en route from our center to the intensive care unit. So they secure those elevators to make sure no visitors or any other employees of the hospital get off on that floor during the transport. Once we get to the intensive care unit, like Tilly said, we do all of our pre-HBO screenings there, vital signs, do all of our safety checks, obtain blood glucose readings from the intensive care unit nurses, and all the patients are transported on supplemental oxygen, surgical mask, and negative pressure hoods. We also monitor our patients' heart rate with the EKG and blood pressure while they're in a dive, so we bring that equipment with us and connect all of that to the patients while they're on their high flow oxygen in the intensive care unit. Patients are then transported back post their hyperbaric treatment using the same protocols. We also talked about maintaining a safe environment for the patients and for the employees. Like Dr. Thibodeaux said, we do have a busy outpatient clinic, so the morning times is used for our outpatients who are receiving hyperbaric oxygen therapy, and the afternoons is when we do the COVID positive patients. So our cleansing guidelines that we developed and implemented here, the chambers are cleansed with the appropriate disinfectants. Disinfectants are applied to the inside of the chamber. All staff still in PPE for that process. We wet the entire inside of the chamber, pressurize the chamber to 3 atmospheres and hold it there for 20 minutes. We then emergency vent the chambers and completely wipe down the inside of the chamber, make sure there's no residue and it's completely dried and cleaned. The outside of the chambers, we disinfect them while the chambers are being pressurized. And we do the same for our stretcher, mattress, pillows, and any equipment that is needed. That is done after every treatment. The environmental services department comes in and does a terminal clean of a hyperbaric facility daily. As of Sunday, it was 21 days that we did patients. So kudos to my staff. They worked very hard, very diligently. And we've seen great improvements in the patients that we have treated. Some of the approved chamber cleansers. Most chamber manufacturers will have an approved list of appropriate disinfectants. We have Secret chambers here, and this is what was recommended by them as a manufacturer. The LPHSE is the one that we use. There's also Aseptic, Virusept, Oxicide, Stat3 TV, and I also have listed the manufacturer who makes those. Quaternary disinfectant, coverage spray, and Santa Claus, the bleach wipes, and also the Santa Claus HB. I have some photos of the transport. These are the oxygen hoods connected to a Gumco suction, so it's got a HEPA filter. These patients are transferred from their intensive care unit bed to our transport gurney with supplemental oxygen through the hood. The Gumcos have batteries, so you don't need electricity for the transport. It's connected, create negative pressure, which protects the corridor as we're transporting the patients. Here are the 4 air air scrubbers, HEPA filters, and it circulates 3,000 cubic feet per minute. So housekeeping, the environmental plant operations came in and installed these into our center here. Took out a window on the left that is to a waiting room. So we've quartered off that waiting room to use it for the flow. And then it is discharged to an external window, and we're on the 3rd floor. So we have no issues with any of the airflow exchange being delivered outside. We worked with Dr. Serena. We did a webinar last week. He's been in development with tissue analytics. They are looking at developing an app. They're about complete with it that we can use and to collect data, place the data into the tissue analytics, and they'll create a database for us. Anyone who's interested can contact Dr. Serena at the email shown, and
Free, app's free.
And
The app's free.
And the app is free. That is correct. And that is all from me. Thank you.
Thank you, Marcus. That was an excellent presentation. The next will be Julio Garcia. He's a board member of American College of Hyperbaric Medicine. He started his career in 1984 as a 91B U.S. Army combat medical specialist. After 6 years of service in U.S. Army, he began his initial training in wound care at University of South Alabama Medical Center. And after his service in war, Mr. Garcia completed his Bachelor of Science in Nursing from the University of Mobile. He furthered his training by specializing in critical care medicine, emergency medicine. And in 1996, he began his full-time career in hyperbaric medicine and wound care. His passion is to really open up 24/7 hyperbaric emergency facility throughout the country. Dr. Julio Garcia is going to talk about what we need to look for during pandemic while treating patient in multi-place chamber. And he's going to talk about HOOD. Go ahead.
Thank you, Dr. Shaw. One of my biggest things that I've noticed here with the COVID virus, when we first started having webinars, I was allowed to view a webinar from Lessons Learned in both New York City and Seattle, and the presenters were pulmonologists and from both sides of the coast. And what struck me was the criteria that they were using for intubation, which was 6 liters nasal cannula with saturation levels less than 90% was indication to intubate the patient. And I also noticed initially on the first reports the use of the non-invasive positive pressure hoods. So on the slide that you see right now is a compilation of all the different resources that I've found just browsing through the web. The most useful, in my opinion, that I've come across is from University of Chicago School of Medicine. If you go to their website, which you can find on that second to last bullet point, they have a resource page that is just chock full of information on how to utilize the non-invasive positive pressure hoods. So these hoods for the monoplace people are not utilized in the monoplace setting because the entire chamber is filled with 100% oxygen. So in the multiplace setting, we use these type hoods to deliver 100% O2. What's beautiful about them, in my opinion, in this particular setting is that we completely contain the patient's atmosphere within the hood. We also can ensure that the patient is receiving 100% oxygen. This does not have to be used in conjunction with a hyperbaric oxygen chamber. This can be used with wall O2, and a PEEP valve is illustrated in that bottom picture there that you see by Sealong Industries. And you can actually produce up to 20 centimeters water worth of PEEP without the use of a hyperbaric oxygen and non-invasively. So this has been a tremendous utilization of these type of hoods. This is not new technology. There was published papers, again, that you can find on those links that I have provided that detail the use of these hoods since 2010, and again published again in 2016. There was a decrease utilizing oxygen hoods like this of intubation by 30 to 40%. So this, even if you don't have a hyperbaric chamber, this is a great way to hyperoxygenate patients that provide PEEP and pressure support in order for those patients to be able to be ventilated. You can also use it along with the prone positioning, ensuring that the tubes that you see on the Amron picture are located towards the posterior or the back of the head. The website that I mentioned on the University of Chicago's website has how-to videos on how to set these up and what pieces of equipment that you can find in any respiratory therapy department that you need. So the big thing, the big purchase item are the hoods themselves. I've spoken with Amron International. I have no financial connections with them or C-Long or anybody else. And Amron has really been hit, along with C-Long Industries, with big orders from around the world, not just the United States. So this is something else that you can consider in utilizing with the treatment of the COVID patient. Again, I hate reinventing the wheel, so some of the things that I look for, and I'm also a member of the Undersea Hyperbaric Medical Society, along with the American College of Hyperbaric Medicine, is resources. Some of the first resources that we saw come out available to our community came from the European Committee on Hyperbaric Medicine, describing their position statements on the use of multi-place chambers and treating the COVID during the COVID pandemic. It wasn't treating the COVID patients, simply what you would do if you are treating patients during the COVID pandemic. That in turn was mimicked and mirrored and used as a resource by the Undersea Hyperbaric Medical Society. You can see the general guidelines there. Of course, screen your patients. Make sure that there are no patients who are actively showing signs and symptoms of influenza type physiology entering your department. Hand washing, sanitation. A lot of the facilities are having the patients also, as they enter into the facilities, wash their hands or use alcohol type disinfectants, and having the patients don their masks. Now, the big difference as far as treating the patients, again, in the monoplace versus the multiplace, in the multiplace, we can immediately or very quickly isolate the patient from the environment. When we place those oxygen treatment hoods, that patient's atmosphere is completely contained within that hood. The inside attendants can be at risk, so one of the things that they're utilizing is shorter and not as great pressures to minimize having to give air breaks to the patients in the multiplace. So they're treating at 2.0, 1.6 atmospheres absolute. That way you can go straight 100% oxygen with no air breaks without the risk of pulmonary oxygen toxicity to the central nervous system. One of the things that was asked also when looking at the treatment hoods is CO2 buildup. If you're not in a hyperbaric setting, CO2 buildup was actually measured by the Amron Corporation, and they at 50 liters, you want to make sure you're using high flow O2. So in order to achieve this high flow O2, you're going to need either multiple IV inlets, oxygen inlets to achieve that 50 liters. And at 50 liters, you're going to be at less than 0.5 percentage of carbon dioxide in the hood. You do not want to have an increase in that carbon dioxide inside the hood. So you definitely want to limit air brakes or make them non-existent in the multi-place setting. Good screening. Your inside attenders can also use the N95 mask. I would prefer, in my setting, I have dual place chambers, so I don't have to have an inside tender, but I would, if I was in a walk-in multi-place, I would want my inside tenders to be either on a bib or aviator mask instead of just an N95. Again, that way you're completely isolating them from the atmosphere. All your normal personal protective equipment that you might need in handling these patients. And again, you want to use the approved disinfectants to protect your acrylic. There is no known contraindication as far as using the recognized disinfectants that we have. They're effective against all viruses that are they're aware of. COVID's no different. So if it's a bactericidal that is effective against all the other viruses, it is supposed to be effective against COVID also. The monoplace, you're going to have to, as Marcus was saying during his presentation, the biggest part is a lot of forethought. You got to think about how you got to get from point A to point B, what possible risks of transmission or allowing the patient to be exposed to the and shed virus into the environment. You can see that Marcus's staff came up with a great plan on how to place essentially an acrylic box over the patient, so if there was a cough, trying to decrease those droplets. Something else that people seem to forget, this is a droplet, not an airborne transmission. So things such as, well, the exhaust gas, unless you're planning to climb up on the roof of a hospital and start sucking from the gas tube, the exhaust tube, there's zero risk of transmission into the atmosphere outside of a hospital. It's got a lot of tube to travel, a lot of piping to travel before it gets to the outside as a droplet-borne infectious process. Use your approved disinfectants. Make sure you're wiping down all surfaces. You're going to have to terminally clean inside the chamber. Mr. Spire, Marcus, Dr. Thibodeaux doing a great job. They've also come up with that they will clean the inside of the chamber, leave it wet with the disinfectants, diving it down to 3 ATA on 100% oxygen, letting it rest for 15 minutes, dry time, and then venting it back up to the surface. Is it easy to do? I don't think it's outside the realm to do. It does take a lot of planning, and I think we can do a lot of good. It really requires, in my opinion, hospital-based facilities, because you never know when these patients might turn south on you, and to have somebody in complete respiratory distress in an outpatient center is not the position I'd want to be in. Thank you.
Thank you, Julio. That was a great presentation. I'm going to now ask Dr. Gelli to come back. Can you please share your screen and talk about the national and international guidelines and side effects with hyperbaric oxygen therapy? Dr. Gelli is currently the medical director of a wound care educational partner. Julio, can you stop saying, okay. Educational partner, hyperbaric physician of Georgia, and a chief executive officer of hyperbaric treatment. She has been actively involved in billing and reimbursement issues for both facilities, physician, and is a co-chair of UHMS Quality Utilization Authorization and Reimbursement Committee and a board member of American College of Hyperbaric Medicine. Dr. Helen Gelli, please take away.
All right, thank you very much. I was asked to go over the possible risks associated with treating COVID-19 patients with hyperbaric therapy. One of the risks would be for barotrauma, especially, let's say, otic barotrauma, if they have very dry mucous membranes from having such high flow O2. But after speaking with a number of investigators, this doesn't really seem to be that much of a problem. The second one would be pulmonary barotrauma. Most of these pneumonias appear to be solid, and you have about the same normal risk for having a pneumothorax. So the recommendation is to get a very good chest X-ray or chest CT, because they may have caused some trauma to themselves due to persistent and hard coughing. Looking through the literature, the COVID ventilated patients developed a pneumothorax 2% of the time versus ARDS patients who developed pneumothoraces about 25% of the time. So the risk is much lower. The next risk that is probably needs to be addressed, although I'm not sure how we would quantify this, is pulmonary oxygen toxicity, because these folks are on very high flow O2 as inpatients, and then we're giving them the added hyperbaric exposure, and depending on the protocol, 90 minutes at 2.0 or 60 minutes at 2.0, and of course it will increase if it's a BID exposure. So as we get more experience, we will be able to parse out what effect pulmonary oxygen toxicity is, what type of a factor it is in these patients' clinical outcomes, and perhaps would look at doing shorter bottom times and potentially lower treatment pressures. There's a risk for confinement anxiety. These folks are hypoxic and they're already very antsy. And this it seems to be, gets better by what Dr. Denham has told me during hyperoxygenation. So they're much more comfortable in the hyperbaric environment. And I think Dr. Thibodeaux also mentioned the same thing, that once their hypoxia resolves, they are much calmer and much more likely to stay in the hyperbaric chamber. The greatest risk from speaking to Dr. Denham, as well as one of the other PI investigators on one of the clinicaltrials.gov, was desaturation during transport. And I think that Dr. Thibodeaux is in an unusual situation where he doesn't have to do a marathon to get from the intensive care unit to his hyperbaric chamber, but that is not true in all of the hyperbaric units. So Dr. Denham has posted on a blog that Dr. Fife is hosting. You have to have a full oxygen tank for transport. You have to minimize their exertion when you're transporting them, and you may need to put the patient on the stretcher in the room, the hyperbaric stretcher, in order to avoid two transfer situations. The risks are not just to the patient, they're also to the staff, to other patients during and after their treatments, to transmission to the rest of the wound center, especially if you're transporting the patient through the wound center to the hyperbaric unit, transmission to the hyperbaric equipment surfaces, and then with potential transmission to staff and other employees of the hospital. Discussion of the mitigation of these was discussed by Marcus, but in our center we took one more step. We bought industrial UVC lights for the clinical spaces and the bathrooms and the changing rooms. And if you look at the one that's over here on the far right, that will clean a 1,000 square foot room for 1 hour, but you need to make your own blackout 100% UV blocking covers for the monoplace because of the acrylic. So I added a slide here, questions from the webinar, what other modalities were used, and I just texted Dr. Denham, and she said nothing, not even PEEP. Convalescent plasma for the intubated patients as was available, but it's not standard protocol. And there was a question on how is it being funded. So the trial that Dr. Denham is supervising is self-funded by the hospital. There's no external funding source. And Dr. Denham is donating her time, so she needs to get more than 1 gold star for that. The next part, I was asked to compare the national and international guidelines. And I have to say that they're really in alignment. There are some differences. For example, in the United States, there are more monoplace facilities than multiplace. Overseas, predominantly multiplace facilities. Everyone recommends no air breaks to minimize the aerosols in aerosolizing the potential virus in the multiplace. And I know that even in our multiplace, when we're treating patients who are now just routine patients, we used to give air breaks. We no longer give air breaks to minimize asymptomatic transmission. We've also started using hoods from the very beginning of the treatment. Everyone has their hood on when they get in, rather than compressing them on air and then putting them on oxygen. In the United States, the recommendation is to defer non-urgent treatments. The international folks concur with that. We all need to be cognizant of an increased fire risk in the multi-place environment from the PPE of the inside tender, although frankly, they have to wear it. So if you're going to do the treatment, just make sure that your fire suppression system works. The United States recommends that hyperbaric therapy be only done under IRB approved clinical trials and in hospital-based programs due to the fragility of the patients and their propensity to rapidly experience clinical decompensation. The Europeans and the international community recommend that they be done under IRB approved clinical trials, but have opened a window for outside of the IRB research setting if there's a careful consideration of the risk benefit for each specific patient, and it's done in a controlled setting, for example, with a physician who's trained in hyperbaric therapy and not in a setting where someone is doing soft-sided chambers. That brings us to the ethical considerations. So there is compassionate use versus investigational review board oversight. In many community hospitals, it is very challenging to get IRB approval, and the community IRBs or commercial IRBs are very expensive. If you track your outcomes and data, that is research. And if you're tracking them and it's researched, you need to have some type of oversight. If you do a one-by-one evaluation, then it's within the physician prerogative to treat quote unquote off-label. It's the physician practicing medicine. It's not the physician doing research. The question of N of 1 studies versus clinical trials that are randomized and have oversight, N of 1 is starting to become more common in the peer-reviewed literature. And so if you have a situation, you can treat the patient in an off-label setting and report it retrospectively as an N of 1 study. The most important thing to remember is to do no harm, and this is a bit of a unknown sphere that we're going into. So we have to be very careful that we don't enhance the damage to these patients' lungs in our efforts to make them better. We also have to consent the patient that this is an experimental treatment, what the alternatives and risks are, and if there's a discussion of payment, it needs to be identified who's going to get paid for what. So at this time, we don't know what the harms might be, and we don't know necessarily what the risks are, but it seems that after doing an informal study, risk or actual complications are very, very rare in these patients, as long as you do a good selection process before putting them in the chamber. And so potentially this can be used in centers that are not 24/7 critical care, as long as they're willing to take some risk in treating these patients. So, thank you.
Thank you, Dr. Gelly. That was an excellent presentation. I think we are kind of over time, so we will not be able to do Q&A, but we will plan to do a second session and give you updates, because we will have more data as we go along. And I really want to thank all of you for attending today's webinar. I really love each and every speaker. They were excellent. They were absolutely phenomenal. Thank you, Dr. Thibodeaux and Dr. Denham, for being the pioneers and starting the work and helping these COVID-19 patients. And I really want to thank you at this point, our general support for this webinar by Seacrest Industry. Thank you to our ACHM board who has helped us with the webinar, our Vice President, Tyler Sexton, Secretary Treasurer Kelly Johnson Arbor, Past President Jeff Nisgoda, and our board members, Dr. Bazzuto, Dr. Fife, who just wrote a blog today about ethical consideration of treating COVID-19 patients. So please see that, and see, has a US wound registry, which can allow you to register COVID-19 and HBO patient. Julio Garcia, Helen Galley, Christopher Grant, Dr. Rafael Raffles, Dr. Wolf, George Wolf, Dr. Gregory Bond, Dr. Sanchez from Mexico, and our executive director, Sari Noonan, who put a lot of hours to get this webinar done. Thank you for help with this webinar. National Board of Diving and Hyperbaric Technology for approving this contact hours so quickly, and Texas Air Medical Association for the CME hour. Please look at the ACHM website and look at the white papers. We will be publishing the synopsis of today's presentation, and there will be an enduring material for the video that you just watched, so you can continue watching whoever have missed it. Please look at our ethical guidelines, UHMS position paper, and white paper on office-based hyperbaric oxygen therapy, which is on the ACHM website. And we'll love you to join our annual meeting, which is the first hyperbaric digital conference, which can be viewed throughout the world. We want all of you to join us. We have an excellent speakers. Please look at our agenda on our website. Thank you so much. And please go ahead and treat all your patients with hyperbarics. Hopefully, we can provide hope for some of this difficult COVID-19 patient, as we see our friends, colleagues, healthcare workers, and patients suffering. And once they get intubated, their mortality is very high. Thank you so much for listening to me and listening to this webinar. And good luck. Thank you.